Let me feel a bit younger also.
Okay. Now, to circumvent the fact that he talks a lot, we will be doing another format where he will have to forcefully talk less. Okay. He, but actually, in the break, the one common thing that many people told me is that he is so knowledgeable that you can't just have one session with him. You will have to have
I'll
another.
be more than happy.
Yeah.
But I'm all in for this, so I will be more than happy. Sir has to call me, so if you don't find me, tell sir.
Yeah. So now I'm doing a rapid fire kind of thing with him on short topics. Topics that we family physicians, generalists face almost every day. Cases that don't go to him despite the fact that they are, rheumat or overlaps. So we discuss quickly. The first topic I'm saying is I'll ask you questions, you give me answers. I'll ask you, give me answers.
Yes.
You can be long. I'm just joking.
No,
You can.
No, sir, we need to be.
Towards the
respectful
time
of the
coming.
Yeah.
The first topic is plantar fasciitis. Plantar fasciitis etiology.
So 60 to 70% plantar fasciitis starts at 40 to 60 years of age. Almost 30% of all of us will have plantar fasciitis at some point in your life. Plantar fasciitis, low back pain, tennis elbow, decurvance, sinusitis, all these stupid disorders, stupid because they're very painful. You will have it. You will have it. One of these four. You will be very lucky to not have any of this during your lifetime. So, very common cause is age, weight, poor footwear, flat feet. But if you have a plantar fasciitis below 30 or 40, I will also start thinking of spondyloarthritis, like psoriatic arthritis, like ankylosing spondylitis, like what is called? Like inflammatory bowel disease associated arthritis, and juvenile patients. If a 9-year-old kid has plantar fasciitis, you have to start thinking of a spondyloarthritis variant of a juvenile arthritis, where they can be actually B20 and positive. This is known as enthesitis. So if I find it is a part of a bigger disease, I call it enthesitis. If I find it is a part of a, let's say, aging between 40 to 60, I call it enthesopathy. You cannot differentiate it. This is a retrospective labeling because you are seeing the other parts and other things of the patient, and everybody knows what is an enthesitis.
And enthesitis is defined as some inflammation occurring in attachments to the bone or.
But this concept of itis and opathy is very vague. So this is all retrospective. So you have to take the whole clinical scenario into consideration before calling it. But spondyloarthritis, spondyloarthropathy, be very careful in using this. Many rheumatologists use them interchangeably. But what I'm trying to say, below 30, start thinking, is it a part of a larger disease? Always ask for psoriasis. And if it's above 30, 40, standard, no other cause, 2-3 महीने में exercise किया,
typically plantar fasciitis is unilateral or bilateral?
It is usually unilateral, but it may become, so if you have one heel affected without any other cause, the other heel may be affected at some point in your life. Similar to tennis elbow, similar to decurvance.
So it can recur.
It can recur in the same fit, especially if you have not addressed the condition.
Is a calcaneal spur possible?
Calcaneal spur is stupid. I don't do X-rays in plantar fasciitis. Almost always the patient comes with an X-ray. I don't see the X-ray. Everybody of you may have a calcaneal spur. 30% of people will have a calcaneal spur without developing plantar fasciitis in their lifetime. The most stupid thing to do is doing an X-ray and telling ये spur है, इसकी वजह से pain हो रहा है. Spur नहीं है तो आपको plantar fasciitis नहीं है.
In one sentence,
plantar fasciitis is pain in the plantar fascia. It is not pain in the calcaneal spur. So do understand.
What is the symptom that they will present with?
So heel pain, typically on the medial side of the heel, posterior medial side of the heel. The first step when they get up after rest, it may be the biggest period of your rest is sleep. So the more the rest, the more the first step pain. So usually the biggest history, the most common history you'll get is when I get down from the bed first thing in the morning, I have to limp for few steps. Then it gets slightly better. If it's a severe plantar fasciitis, the pain will be much prolonged. But usually this is their problem कि जब भी बैठते हैं और उठते हैं तो ऐसे 2-3 स्टेप के लिए हमको कोई लंगड़ा बोल देते हैं. Actually, plantar fasciitis does not trouble them. कोई उनको लंगड़ा बोल देता है ना, that hurts them sometimes. So that is also a problem.
As we discussed before, the natural history is that it self-treats, self-cures.
Like frozen shoulders at
Right.
times.
So, what is the therapy and how can we avoid wrong treatment?
I have not injected a plantar fasciitis for last 8-9 years. One or two I injected was probably premature knowledge, and now the concept is very clear. Injection can be given only once or twice in the whole life, because otherwise you are putting the risk of plantar fascia rupture. It is very
He's
difficult.
talking about steroid injection.
Steroid injection. It's very difficult to treat plantar fascia or Achilles tendon rupture. So the general concept is take care of the footwear, give lot of exercises. The most difficult thing is exercises. 90% of patients don't do even by my third visit, with a short course of NSAIDs. I have given 3 months of NSAIDs also, but I have said I will not give injections. And even the severest of the patients have got better for 4 to 6 months. And if they have not got better, I have said leave with it, because injection may give you relief for 4 to 6 weeks. If you want to try it, I can give it, but it may come back with a vengeance. If you are ready to accept that, I am ready to give it. Because if most patients, if they do proper exercises with good stretching of their plantar fascia and a good footwear with correction of flat feet, 90% will have a reasonable quality of life. And injection may give you dramatic pain relief, but that area is so restricted that may lead to immense pain at the start, or it may give a lifelong pain also, and may put at risk of plantar fascia rupture also. So I am very strictly against tennis elbow and plantar fascia injections.
There are several good YouTube videos of exercises for plantar fasciitis, but if you can demonstrate 1 or 2 exercises that is commonly advised.
I think the best exercise is this. But the biggest problem is now most patients will do this and leave it. You have to really stretch. And the biggest problem is this extreme level of stretch. You need a person to stretch your ankle or stretch your hip. Or you can take a band. The second most common thing is take a bottle, just make it filled with water. It should be ice or balan. So there are other uses of balan also. So, and rolling. So rolling pin is what is the word used. And I think even these exercises so what I tell patients, you give some fermentation or soak it in water and then do 15 minutes of exercises. You don't do it 10 times a day. It's not possible. You do it once a day, but do it regularly and don't stop it. That is what I did. I have a lupus patient who has plantar fasciitis. हर बार दिमाग खाती है. मैं हर बार पूछता हूँ एक्सरसाइज किया. इस बार उसके पति आया तो बोला कि सर आप 2.5 महीने से बोल रहे हो, उसने एक भी दिन एक्सरसाइज नहीं किया. Then it got revealed कि I was thinking of injecting her. It was so bad. But she has not done a single day of exercise and she is expecting relief from me.
Yeah, Devesh at some point. Exercise relief.
No. TheraBand नहीं sir, वो towel. हाँ.
Towel, yeah, dupatta type of thing. You can, dupatta is a good thing.
Sir, ज़्यादा अगर
you said correct the flat foot.
Flat foot insoles. I'm not good at that part, and every modality in this kind of pains has a success rate of 30% only. So don't think कि you giving insoles will go away. It may go away. But I say कि you try all 3 modalities, but exercise is most important. And same thing for tennis elbow. आपको बैंड बांधना है बांधो, कुछ भी करना है करो, बट एक्सरसाइज नहीं करोगे तो मत आना. उसके बाद फेल हुआ तो यू कैन गिव PRPs and whatever steroid injections and stuff like that.
Also seen in fasciitis?
No. It's a part of a larger
Let's
disease.
go to tennis elbow since we discussed. You said again steroid injections are not first line of treatment. What kind of exercises?
So there are lot of extension because this is the one which creates a lot of pain. So you have to extend your tennis elbow is basically the lateral epicondyle pain where your extensor apparatus gets attacked. So the wrist extensor. So if you extend the wrist and you need to stretch and strengthen the elbow. So what you are doing in this exercise is you are making the tendons and muscles much stronger. And you are probably causing some micro injury at those sites, which leads to further healing, which is what happens with needling, which is what sometimes you do with ultrasound where you're giving small pulses, and which is what some things you are doing with PRP also. But I usually say ki if you strengthen your apparatus well surrounding your elbow, you will not feel that much pain and the inflammation may subside. But having said that, there are some patients who are in lot of pain, and in those patients you may use injections, you may use PRP, and you may do surgery also. But if you see large cohort of trials, more often than not, surgeries were also not very effective in the long run compared to vis-a-vis physiotherapy. Now everybody gives the example of Sachin Tendulkar, but he needed to go to sport very soon. So, and he did try a lot of physio first for 3-4 weeks. They also probably gave him a steroid injection, but it did not work. So this was a person जिसको अपने को cricket field पे जल्दी लाना था. So surgery is indicated in those patients. But maybe 1 year down the line, he would have had the similar history. We could not wait for 1 year. So in most patients, because it tends to recur again. That's why you should use your modalities very sparingly. Tennis elbow bands for 10-15 days, similar to using a lumbosacral belt for 10-15 days. Any long-term belts will cause muscle weakness. But if you have a very bad tennis elbow and you can't find any other treatment modality, you can use a band while you are doing heavy works, because you can't ask people to stop work. And there are some patients who are doing them. Learn to accept that you are not going to be able to treat every pain out there. So that is the limitations you should be able to live with.
Can you demonstrate for the students what test you will do for the
no. So no.
the lateral epicondyle.
So I just touch the lateral epicondyle, and if it is very painful, this is tennis elbow. You can do a wrist extension, but really doesn't matter. Tennis elbow is very easy to diagnose. Yeah. But not every elbow pain is tennis elbow. You should have pain at the lateral epicondyle. Here, that is not. A lot of chronic pain patients, we touch like this now, they will say. So this is the point of tennis elbow. This is the point of dorsal pain. जहाँ पेन होता है ना, तो I am not very sure, but the tendons are attached here. So this is the pain now. So I say you do a tennis elbow exercise, but I am not convinced the diagnosis of tennis elbow. And anyways, in pain it does not matter. 90% of pains get better with exercises. So मेरा एक ही भाषण रहता है, पहले exercise करो, फिर आएंगे, देखेंगे.
Okay, we go on to
tennis elbow. There is no cause. There is overactivity. There is weight theory. There is theory of if you have a psoriasis, it can lead to tennis elbow also. So only thing when I'm worried is I recently saw a very big surgeon who had a history of inflammatory bowel disease 10 years back. And now he has points which are hurting him. And what are the points which are hurting him? Back of the Achilles, back of the heel, where the Achilles is attached, both his lateral epicondyles and both his medial knee epicondyles. These are the sites of enthesis, where the tendons get attached. He does not have history of psoriasis, but he has a history of inflammatory bowel disease. And now spondyloarthritis is a group which leads to lot of enthesial pain. But he has no joint swelling. And he is very discomforted. So much so that मेरा quality of life बहुत गिरा. Excellent swimmer. If you see his physics now, he is probably 55, but he looks 40. It's very physical. I thought he's going to gym. So he's like, my quality of life has become miserable. So I said, maybe you are having some enthesitis related arthritis. There is no blood test to prove it. All blood tests are negative. And you have a history of inflammatory bowel disease, which is known to have enthesitis. Enthesitis occurs in spondyloarthritis group. Ankylosing spondylitis, psoriatic arthritis, inflammatory bowel diseases, and reactive arthritis and juvenile arthritis, which are HLA-B27 positive. So enthesitis is like the thing in these diseases which differentiates them from rheumatoid arthritis. So I offered him, let's try sulfasalazine and see. But that's also with half heart. I am said, sir, maybe you will have to live with these pains, or we try sulfasalazine and methotrexate and see how it goes. Let's see how it goes. So he has only enthesial pains. So in this patient, the tennis elbow is technically tennis elbow, but it's a part of a larger picture. But most tennis elbows and most plantar fasciitis are idiopathic. You will have it between 40 to 60. You may have it unilateral, you may have it bilateral, and it's very common. And you have to take out the weight, take the exercises and use lot of fomentation, and most patients will do better.
Carpal tunnel syndrome. Of course, carpal tunnel syndrome has etiologies. So, one, what is the symptomatology which will make you suspect carpal tunnel?
So any patient who says ki I have lot of right tingling in the hand, especially in the in
Medial.
so medial, yeah. So this part of the okay. So I start with the thumb, 3.5. This is the area of medial nerve territory. But most carpal tunnel patients will not say that I have tingling and pain in the half of the hand. They will say कि मुझे राइट में हाथ में बहुत झुंझुनाहट होता है. And when you ask them specifically, is it restricted to probably 3/4 of the hand? They'll say yes. And sometimes they will be very, very categorical in marking the territory. So median nerve territory is up to the half of this finger. What do you call it? Ring finger. So up to the half of this. Starts from thumb. If you see net diagrams, very classical pictures are there. Because when you compress it here, this sensory territory is this much. This is sensory territory. I am not talking of the motor territory. And they may start dropping things because their pincer grasp getting difficult. So this grasp getting difficult. So usually carpal tunnel is sensory because sensory fibers are more predominantly affected, more night pain, and you can have difficulty in. You said some test. So this is a test where I ask the patient to hold this for at least a minute, and if you get a similar sensation precipitated, again carpal tunnel syndrome, or you do a prayer sign and see whether, because you are stretching, you are stressing the nerve in the canal. When you are doing this, you are trying to compress the already compressed nerve in the canal. Now these are not very useful. The most sensitive and specific test is NCV. NCV, sorry. Not EMG. Nerve conduction velocity. So not every patient needs an EMG. If you are thinking carpal tunnel, just order an NCV. Don't order an EMG. NCV is good enough and it is very sensitive. Most NCVs in Bombay are done by technicians. The only thing you can trust upon them in NCV is carpal tunnel syndrome. Rest all, never trust. There are good neurophysiologists now. So if you are planning an EMG NCV, either go to Bombay Hospital or go to a good neurophysiologist, because it's not an easy thing. It's a very difficult thing to do an EMG.
Treatment of carpal tunnel.
The carpal tunnel, usually I don't get into that territory. If it's a pure carpal tunnel with motor involvement, they will definitely need surgery. You have ruled out rheumatoid arthritis, you have ruled out hypothyroidism, you have ruled out amyloidosis or any malignancy. But most of the times I don't get carpal tunnel despite rheumatoid arthritis, because their joint symptoms are so predominant, they are not worried about the carpal tunnel. Somebody has done an NCV and found out a carpal tunnel, which you will find with a wrist swelling. So that is
one thing that I can say is that the splint of
yes. So I was going to come back. Splints, if you have sensory symptoms, splints and pregabalin can be very, very helpful. You don't need surgery in every carpal tunnel. In UK, we had a hand surgeon who said कि आज नहीं तो कल कराना पड़ेगा, which is true in pure carpal tunnels 50 to 60% of the times, but 30 to 40% of patients can go without surgery for 10-20 years also, and maybe lifelong also. So not every carpal tunnel needs.
One study that probably is quite a good study is that pregabalin, gabapentin are placebos in carpal tunnel.
Yes.
So maybe splint for us.
Yeah, splint, rest, and I always give carpal tunnel exercise videos. There are proper carpal tunnel exercise videos. It may overlap with your wrist arthritis exercises, but at least you have something specifically made for them. So patients get better. अच्छा CTS का video भी है, मेरे को दे दो, मैं करूँगा. But again, my initial भाषण on all these therapies is exercises. If you don't do exercises, don't come back to me.
Another minor disease which is painful is greater trochanter bursitis. Can you tell us the location and the symptoms?
So any patient who is telling you कि मेरे को इस territory में pain होता है, most of the times MRI spine is done normal. Something is done normal. Nobody has got up and touched the patient. So this is the site of pain, your greater trochanter. It's very, very tender, and this can lead to a lot of pain in this territory. So always palpate, because if you are going to order an MRI without actually palpating the patient, you are going to get wrong. I'll give you two examples. I had a patient of 28-year-old female who, anybody has an osteitis condensans eyelid?
I don't know what that is.
No? You don't know? So osteitis condensans eyelid is basically sclerosis of your SI joint. Very common in postpartum females. Almost 20% or 10 to 15% females will have osteitis condensans eyelid. Now what happens in osteitis condensans eyelid is you get lot of sclerosis in the SI joints, and that can be misinterpreted as sacroiliitis, chronic sacroiliitis by many radiologists. So now what happens? You have a young female coming to you, let's say 40, 45. She complains of lot of pain in this area. Okay? You are not an experienced person. You do an MRI. MRI pe aaya, there is lot of sclerosis in the SI joints. They have not mentioned on SI joints space. They have not taken CT cuts to look for erosions. And there is no inflammation. So a non-good radiologist may say कि this is sacroiliitis which is chronic. Back pain है, young है, थोड़ा बहुत early morning stiffness तो मिल ही जाएगा. Label हो गया spondyloarthritis. क्या मिल गया? Sulfasalazine. ठीक है? Where this was just a postpartum osteitis condensans and you needed to give a physiotherapy. Maybe her back pain was related to sclerosis, maybe it was not. Because everybody knows that MRI spine does not correlate with external pain. Everybody agrees with that. MRIs are stupidly oversensitive in diagnosis which are not required. So now this female who came to me, she was being treated by a good rheumatologist. When I use the word good, I don't mean any offense. I will trust that rheumatologist with my relative also. She was being treated with sulfasalazine for 2 years and she was frustrated because there was no pain relief. So pehle to I saw the MRI, I am like, we are good at picking SI joint MRIs. I am like, this joint line is very well maintained. There is no erosion on the MRI. There is no inflammation of the MRI. And even OCI can give you some subtle signals of SI joint. Even today, if you do my MRI SI joint, you can get a signal, especially if I am a laborer or a cycler or somebody who is a sport person. So SI joint signal does not mean sacroiliitis. It can be a normal signal in a person. So you have to go back to the history. This patient did not have a history which was very classical. And I asked her, where is the pain? She said, I cannot walk with this leg. I'm like, okay, ठीक है. अगर दोनों side osteitis condensans का भी pain है तो दोनों side होना चाहिए. I just made her lie down. I just touched her greater trochanter. Her greater trochanter was extremely painful. Okay? So we stopped everything. I start with exercises, with greater trochanter exercises. With exercises, maybe her back exercises or hip exercises, जो भी है, she got almost 90% better in 3 months. And we removed the label of spondyloarthritis. We stopped her sulfasalazine. We just labeled her as possible greater trochanteric bursitis. And if she had not got better, I would have injected the greater trochanteric bursa. Because frozen shoulder and greater trochanteric bursitis are somewhat very steroid responsive. So but still, exercise is the first thing. If you are not responding, then I have a low threshold for injecting this area. Now, the problem is, many a times I see greater trochanteric pain में MRI lumbosacral spine हुआ है जिसमें कुछ आता नहीं है, जबकि किसी ने उसको टच करके देखा ही नहीं. And this should have been done by most orthopedicians, but you have to see that आजकल कोई patient को touch कर ही नहीं रहा है. Pain होता है ना, I know it is a radicular pain. I know it's an L4, L5 territory pain. MRI करेंगे तो slip disc आएगा. I still make the patient lie down. I see that their greater trochanteric bursa and hip rotations are okay or not. Because those may be something else. You have a classic radicular pain, I will still give exercise. But when I have a greater trochanteric bursitis, I may give exercise plus something else. Because lying on this side of the bed becomes very painful for them at times. And many RA patients complain of RA patients tend to have lot of bursitis. Psoriatic arthritis patients tends to have lot of enthesitis. This is an enthesis. So they can also have greater trochanteric pain. I had a child who came with greater trochanteric pain with severe swelling on MRI, but he was labeled as psycho because he used to limp. Because of this pain, he had nothing in the SI joint, nothing in the hip joint. His MRI SI joint was normal. His MRI hip joint was normal. But there was a signal in the greater trochanter which nobody picked up. And everybody thought he's psycho. But he was a juvenile variant of spondyloarthritis who only had greater trochanteric enthesitis, and we treated it, it got better. So these are the context.
A simple
clinical
thing that
context.
we can do.
Yeah.
Another bursitis. Can exercises be given in acute
They
pain?
can be given. You can ask the physio to give some TENS and USG, take away the pain, and then start exercises. Even in absolute agonical acute pain, you will not do exercises. But you have mild to moderate pain, which has been going for many years. Then I say you straight away start stretching, give them an NSAID cover. But start stretching. चाहिए तो 4 to 6 weeks के लिए NSAID cover दो, because they will not do the exercises. 4 to 6 weeks of NSAID cover plus exercise is far better than not starting only exercises and saying कि मेरे को pain होता है मैं नहीं करूंगी. Because every time they will come monthly for pain. You have to push them to exercises anyhow. So first visit I take away the pain. From second visit I start my bhashan. By fourth visit some 90% patient will start doing some exercises. This is my usual success rate in the clinic.
Another bursitis is pes and serine bursitis.
So pes and serine.
Pes and serine bursitis.
I think it's an overrated concept.
Okay.
You see lot of patients with knee pain having pain here. This is the site of pes and serine bursitis. So pes and serine is basically a word. No idea. I thought I am looking at Tushar sir because I think he's the quiz master now. So I think
Goose neck.
goose neck. So I think the shape of the tendons where it is attached looks like some leg of the gooseneck bird or something. So it's known as anserine bursitis. तो वहां पे जहां टेंडन पॉइंट अटैच होता है वो बहुत साइट ऑफ कॉमन पेन है. सो वेन एवर यू आर लुकिंग एट नी पेन, यू आर लुकिंग एट बैड नी ओए, don't always think the pain is coming from the knee. Look at the surrounding structure. There will be pain here, there will be pain here. Now this is a two common site. One is the common site of stress fracture and other is anserine bursitis. Stress fracture treatment is very different. You need to give a lot of rest. And anserine bursitis you can inject with steroids or give exercises and NSAID. Again, I have a context if I can. So recently there was a patient who developed statin-induced rhabdomyolysis. Very severe rhabdomyolysis, required dialysis because rhabdomyolysis means you suddenly have muscle breakdown, kidneys shut down, went for dialysis. He was given 2 drugs. I don't remember, statin plus clofibrate or something which precipitates rhabdomyolysis. Given a lot of steroids. The daughter was an SLE patient, brought the father to me. He had a very severe swelling here. So I am like, अरे classical anserine bursitis है और कुछ नहीं है, inject करेंगे. Because बहुत pain था, CKD था, डायबिटिक था, स्टीरॉयड देना नहीं था, अभी तो सब स्टीरॉयड दिया था, एंड CKD था, तो एंसर्स आउट ऑफ क्वेश्चन था. फिजियो तो वो एग्रेसिवली वैसे भी मायोसाइटिस के लिए कर रहा था, तो मैंने बोला, और इन्फ्लेम लग रहा था, इट वाज लुकिंग वेरी इन्फ्लेम. So I said कि, and she had applied eyes, everything had happened for last 1 month. So I said कि let's probably inject it straight away, though I am not a big fan of injection. But I said कि एक बार MRI करा लो. So when we did the MRI, what came out कि he is having severe knee OA, but because he received so much steroids, knee OA की वजह से this medial compartment is getting compressed. So you have this your medial femoral condyle and tibial condyle already putting stress on each other because the medial cartilage goes away more frequently in the knee pain. So he was already having mild varus. So those compartment was getting compressed and the medial tibial plateau had a stress reaction. Basically stress reaction में क्या दिखता है MRI में? You get a small line with lot of fluid around it. And the radiologist will say this could be a stress fracture or a stress reaction, which basically means that the bone at that area is has micro crack, and that is leading to a lot of edema around it. This patient needs bed rest and offloading of the joint. And maybe his knee OA is that severe, he may need knee replacement. But the precipitating factor may be steroids. So a severe knee OA patient can get stress fracture and pain. So if you have sudden acute onset pain in this part of the thing, even in RA patient, think stress fracture. I have learned it the hard way. I have had RA patients, हमने दिया था उसको वाइसोलोन 20 मिलीग्राम, भयंकर पेन होना, पेन भी जॉइंट के बाजू में था, पेशेंट 5 दिन से 6 दिन से 10 दिन से वाइसोलोन दे रहा है, पेन नहीं जा रहा है. So I called her in the clinic. We thought, and there was no knee swelling, and she kept on complaining of pain. We palpated the medial point, very tender, and turned out to be stress fracture. Now we pick one stress fracture every 3-4 months. So it's not that uncommon because the medial cartilage is degraded and there is a lot of stress going on there. So always pan-sensory bursitis is not very common. The many females have fat here and it pains a lot. My boss used to see that this is like pan-sensory bursitis and he used to ask steroids in this fat pad, but I don't think it works. I think it's better to get physio and some NSAIDs rather than injecting the patient.
Okay, then Baker's cyst.
Okay, so there are symptomatic Baker cysts or symptomatic Baker cysts. If you have a very good full-blown Baker cyst which is making the patient stiff and you think it is the reason of pain, aspirate and inject it with steroids, patient will be much better. I remember my first patient in when I was doing my DM. He had grade 3, grade 4 knee OA.
So
But-
just for the students, Baker's cyst is a collection of fluid.
In the popliteal fossa, it's basically your synovial outpouching which gets collected with fluid. It can be degenerative Baker cyst or it can happen in any arthritis. For example, rheumatoid arthritis patients can have a Baker cyst. Now, Baker cyst can be symptomatic or can be asymptomatic. So this patient had a grade 3 OA. So when you have a knee pain patient with grade 3 OA not responding to everything, what is your first reaction? Replacement karna padega. So we examined him. He had a very large Baker cyst. What was happening? That Baker cyst was obstructing his movement. So what we did, we aspirated the Baker cyst and injected it and gave him exercises. For 3 years, he used to come us to just say hi. We did not give him any treatment. So you have to see the context. Now this is not very common. If you have grade 3, grade 4 OA with Baker cyst, most often than not, you will require replacement. But if you have a RA patient who is complaining of persistent knee pain, आगे से कोई swelling नहीं दिख रहा है, बस पीछे से सूजा हुआ है, या sonography पे पीछे से सूजा हुआ है, you have lot of stiffness near the hamstring, you can see lot of fullness. On MRI you can see a large Baker cyst. I will get it aspirated and injected it. It's not very common in my practice, maybe once in 6 months. More often than not, we see Baker cyst rupture. क्या होता है? They have a undiagnosed Baker cyst which is sitting there. Suddenly one day it decides to rupture. When it ruptures, suddenly you will get this massive swelling of lower limb where you will have to do a Doppler to first rule out DVT, and the Doppler guy will mention कि शायद Baker cyst rupture हुआ and there is lot of fluid along this sheath and patient is having lot of subcutaneous edema. In these patients I give NSAIDs and lot of rest. It will resolve in 3 to 4 weeks. Just try to see that they are stretching their ankle and exercises because they should not develop a DVT because of rest. So Baker cyst rupture is very common.
For us, the important thing is patient comes to you with acute swelling of the calf,
Yes,
which is
I was going to
painful,
say that. Yes.
and you will think of DVT as the first possibility. Always think of the possibility of a rupture.
It may look cellulitic also. It's always okay to be cautious and give a course of antibiotic if you are not sure, because you need a good radiologist to suspect a ruptured Baker cyst, right? Because it is ruptured and you are just seeing a sheath of fluid or subcutaneous edema, and especially 4-5 days later you may not see the fluid. You will also get a lot of lateral ankle swelling because all the fluid is gravitating towards there, but that can be seen in DVT also. So and if you have a RA history and a history of this kind of symptom, it is ruptured Baker cyst. So we see one rupture maybe once a year because we see a lot of RA patients. But usually ruptured Baker cyst may go to GPs.
Okay, the querulence tenosynovitis. The querulence is of two tendons here. First, we'll tell them about the Finkelstein.
Yes. So decurvance tenosynovitis is also known as mommy's thumb.
Mommy's thumb.
So it happens a lot after pregnancy. So basically, this is your anatomical snuff box. This is your anatomical snuff box. The tendons lateral to this snuff box, this part. Okay, there is a sheath here. If you just Google decurvant tenosynovitis, you will see two tendons coming here, forming the lateral boundary of the anatomical snuff box, and they are covered by a retinoculum. Okay, the fact is it's a like tendon under the retinoculum, and they are constantly undergoing these motions, and sometimes they get inflamed. You get lot of pain. Patient will say wrist. You have to go and touch the patient to see whether this is painful or this is painful. So if this is not painful, this is not wrist arthritis. I have made mistakes where I labeled a patient with wrist arthritis and started on DMARD when she just had a pure decurvance tenosynovitis. Decurvance sinusinovititis can occur with RA patients, but more often than not, it's like tennis elbow and plantar fasciitis, where it occurs as an isolated phenomenon. The most common test is you you are having a tendon pathology which is there on the lateral side of thumb. So this movement should not be painful, but this will be painful. So patient बोलेगी भी ना कि मैं आटा गूंथते time painful है. You have to look at the patient. You have to see whether this is painful or this is swollen, not swollen. This side may be swollen, and the commonest, easiest test is colleague who got pregnant while rheumatology training, delivered, and came back to posting, had severe bilateral decurvance. We treated with lot of exercises and NSAIDs for 2 months, and half of the time she used to see OPD, आपको decurvance है, मेरे को भी है. And I kept on saying we may need to inject it. We injected it for after 1.5 months of therapy. She got much better, but she still has persistent decurvance, and we'll need to operate it because it's very bad. And decurvance is one thing where you may need surgery more frequently than any other pathology. Some decurvance will go away, but otherwise you will have to release that reticulum. It is very, very painful. It may seem very easy to you. One of the most painful conditions out there. The patient का सारा काम अटक जाता है because जहाँ पे भी ये twist है, ये आएगा ना, it likes suddenly you have touched a very hot thing. It is that painful. So sometimes and you cannot inject decurvance also repeatedly because you can rupture the tendon. So once or twice maximum. So today, nowadays, some orthopedics hand surgeons straight away advise surgery, which is technically not wrong, but exercise करके देखो, NSAID देके देखो, और
there's a splint also for that.
Splint है, but sometimes doesn't work. Decurvance is very irritating to treat. So I tell patients, one-time injection, no relief, go for surgery or live with it. Which is not going to kill you, but you may have to go for surgery if you want pain relief. My colleague has also not doing surgery क्योंकि उसको rehabilitation के लिए 10-15 दिन देना पड़ेगा. So she's like चल रहा है, but very painful. She's just जैसे उसका हाथ ऐसे करेंगे ना, you have to give her pain. उसका हाथ खींच लो. So that is how it goes.
Chikungunya. So a lot of us deal with chikungunya monsoons here. Definitely, it's not difficult for us to diagnose chikungunya.
Very easy.
But it is difficult for us to not harm the patient. We have to refrain from harming the patient. So what are the things that we do wrong?
No, I think GPs do much better than what we do. Only thing is they don't prolong the drugs when it is needed. So I think everybody fears NSAIDs and steroids too much. When I went to UK, na one perspective it changed. तो 3-3 महीने का NSAID prescription देके घर भेज देते. Very funny. I'm like, नहीं, वो बोलते हैं हाँ 33 years तक का भी डेटा है कि आप लो डोज में इंटरमीडिएट NSAIDs दो तो कुछ नहीं होता. They show data. So what I'm trying to say कि chikungunya very typical post viral. Nowadays what chikungunya you will see will have lot of foot synovitis, lot of foot swelling. So fever आया, fever के second day या fever के दिन से sudden pain हुआ, very florid pain, so much so that you are unable to move, and slowly it will taper off. If it's not tapering off, give a low dose of steroid, give a low dose of NSAID and persist, and ask patient to do lot of exercises so that their tendons get stronger and slowly you can taper off. We do give a lot of DMARDs also, but frankly speaking, within 3 months, the role of DMARD is a question mark. But abhi kaisa hai na ki I am getting a patient 6 weeks into history. Still they are having lot of pain, lot of tenosynovitis. So I say कि ठीक है DMARD देके देखेंगे, but आप exercise करो. अगर 6 महीने में चला गया तो I will stop. And in most patients I have stopped. Almost all patients I have stopped. But even if your chikungunya is negative, you have fever, you have sudden foot swelling, sudden hand pain, it is chikungunya unless proved otherwise. If you are feeling very good about it and spending some more money, you can add a PCR if IgM is negative. But even if PCR is negative, sudden fever, sudden joint pains is post-viral arthritis. Usually it does not last longer. There are case reports where patients started with chikungunya arthritis and developed into a full-blown RA with RA factor and anti-CCP positive. Very, very rare, not very common. I usually tell patients, you will settle in 3 to 6 months. You may be left with mild residual joint pain, But if you try to do exercises and make your muscles stronger, you will be able to bear it. Chikungunya leaves a residual pain for years. It's very difficult. And you give hydroxychloroquine, methotrexate, it doesn't matter. It's better to tell patient to not take drugs and focus on the exercises if there is not much pain. If there is too much pain, I yesterday have written a GP who still has lot of foot swelling 6 weeks into the post-viral arthritis. I have asked, he was continuing Predmet 2 mg which he had stopped, but he started limping so much that the family members brought him. GP sir तो वैसे भी concern नहीं थे, बोला limp 1-2 महीना कर लूंगा but निकालूंगा. So I told him you continue Predmet 2 mg with naproxen 250 half BD minimum dose and with hydroxychloroquine and you should settle in 3 to 6 months. आप 3-4 हफ्ते के बाद थोड़ा थोड़ा टेपर करो पर बंद मत करो. So 6 to 12 weeks of low dose NSAID is fine. Naproxen we consider very mild. Even full dose naproxen we think it is much milder than diclofenac and etocoxib. And it will not work in many, but I think it's a generally safe drug to give. So I am fairly okay. No, I do a baseline RA factor anti-CCP in all patients, even if I'm sure it is chikungunya. Because sometimes I have seen patients who have had RA who have got a flare due to chikungunya. And sometimes a subtle RA may have been missed due to chikungunya. And any which ways, this is an era of not missing things. So I will do a baseline, and after 3 to 6 months, if they persist to have issues, I'll do a repeat autoimmune profile again.
Okay.
So, it's absolutely fine. When you give a depot injection 120 milligram, suppose it's lasting for 30-40 days, it becomes a low dose technically. You are talking about 4 milligram per day. But sometimes what will happen, depot will not work more than 3-4 days. And you can't keep on giving 120 milligram. I'm always thinking cumulative days. Total कितना milligram steroid गया उनको. तो मुझे लगता है कभी कभी 2 milligram per day is not that high. Because suppose the depot lasts for only 2-3 weeks, 80 milligram. You are still giving more dose of steroids than what you will have been given in tablets.
Compliance and easy.
No. I think, sir, steroid in any form in the lowest possible dose for the shortest period of time. NSAIDs and steroids, lowest possible dose, shortest period of time, and remove as soon as possible. Depot gives control in your hand. So we love depots because अगर पेशेंट को ओरल स्टीरॉइड सूंघ लिया और पता चल गया कि इससे मैं ठीक होता हूं तो सब डिमांड्स बंद हो जाएंगे और वही चलेगा. Same too for rheumatoid cases. I tell them this is steroid, don't keep continuing this. But still 1 out of 100 will do that. 6 महीने से स्टीरॉइड ले रहे बाकी सब बंद कर दिया. अब याद क्यों आए कि स्टीरॉइड लेते हुए भी ठीक नहीं हो रहा. Fortunately we don't give too high a dose of steroid. And sometimes in rheumatoid 4 milligram steroid is not enough. You need 20-30 milligram. So we are very cautious of not giving very high dose of steroid. So these patients will come because 4-6 mg steroid chikungunya mein is very effective. But rheumatoid mein it is not that effective. Rheumatoid mein you need to give it with DMARDs, then only that steroid will work much better. But in chikungunya, even if you give 2-3 milligram per day, it is very effective, very effective. That is why it is easy to treat because you just need a small amount of steroid and a small amount of NSAID. And 4 to 6 weeks भी दिया ना तो कुछ फर्क नहीं पड़ता है. And you patient gives a very good quality of life. So that is easy to do.
That brings me to steroid, long-term steroid. Give me 4 or 5 examples of rheumatologic disorders where steroid will be given for more than 1 year.
Definitely bad RAs. There are some bad RAs where you can't give anything else and we feel much safer with low dose steroids. So if you ask me which is more safer from regards to infection, I think low dose steroid is probably safer than tocilizumab also. But it's just that when you take tocilizumab, your quality of life is much better and you can prevent long-term complication of steroids. You understand? But if it's a non-affording patient and there is a just 3-4 milligram steroid required, I may continue it for a year. In most severe lupus patients, most rheumatologists don't stop below 5 milligram. I try to stop it. I don't go by the severity of disease at the start. I have had lupus patients who have had cardiac arrest, whose brain was fired, who had severe lupus nephritis. They survived and we have stopped steroids after 2 to 3 years. But many lupus specialists, people who are big researchers in lupus, will say कि 5 मिलीग्राम वाइसोलोन और 2.5 मिलीग्राम वाइसोलोन इनमें कभी बंद ही नहीं करने का, बिकॉज लूपस इज वेरी वेरी अनप्रेडिक्टेबल, वेरी सीवियर आर वेरी सीवियर लूपस. I don't think anywhere else. Non-rheumatological, तो you know, asthmas and IBDs and
So,
ILD is one thing.
rheumatoid lung,
or even other ILDs. A small dose of steroid, you may see Dr. Udvadia's prescription, 5 milligram Visolone for 6 months, follow up after 6 months. He is not incorrect, because the low dose steroid may be far more effective than using mycophenolate. We tend to give mycophenolate and do a lot of things, but it is not wrong to give a low dose steroid and leave it, because that may be the only thing which may save them from going into a lung bad fibrosis. Because the effectiveness of a steroid cannot be matched by any other drug when it comes to severe autoimmune conditions. So sometimes that is the beauty. So sometimes when we are seeing कि हमने cyclophosphamide भी दे दिया, mycophenolate भी दे दिया, तो भी lung fibrosis progress कर रहा है, तो हम बोलते भाई लो डोज स्टीरॉइड पे चालू रखो, शायद 20 साल और जिएगा, नहीं तो 6 महीने भी नहीं जिए. I don't talk about GCA and temporal arteritis, not very common in Indian context. We used to see one new temporal arteritis in UK, but in India it is
polymyalgia rheumatica.
Polymyalgia rheumatica is very uncommon. These are Caucasian disease. So I think pure polymyalgia rheumatica, where I am convinced there is no other alternative diagnosis, I only have 3 at the moment. So I don't think it's a very common disease. Polymyalgia rheumatica and giant cell arthritis in the form which is described in books is a Caucasian disease. It's not that you have unheard of, but जो कोई rheumatologist इंडिया में बोलता है ना मेरे में GCA अनकॉमन नहीं है, वो GCA एक ही पेशेंट 6 लोगों ने देखा हुआ. So I have only seen 4 or 5 in India. And even in 2 of them there was no temporal arthritis. They had large vessel aortoarthritis. Aortoarthritis is, if it's in young, it's called Takayasu. If it's in old, it's called giant cell arthritis. So that is the difference.
Okay, so long-term steroids, if you have family physicians have patients who are taking long-term steroids for whatever rheumatologic disorder, how does the GP monitor for side effects of those steroids? Every month, every 3 months, every 6 months, every 1 year, what should they do?
So it all depends on the context, but mota if you are giving a low dose steroid and the patient has been stable on it and the doctor is not increasing it, you are going to do the same thing. You are going to optimize their blood pressure, because blood pressure can go haywire. You are going to see whether they are developing diabetes. You are going to see whether they are developing osteoporosis. Young patients are resilient, so I don't usually give bisphosphonates in 30-year-olds, 40-year-olds who are in low dose steroids. But the moment the patient is post-menopausal or above 65, my all low dose steroid prescription even for 3 months will receive a bisphosphonate prophylactically to prevent glucocorticoid induced osteoporosis. We will be very closely watching their sugars, and we will also be looking whether they are developing blurring of vision, because cataract is very very common, and rest of the things you can't really control. Your only job is to try to decrease steroid as much as possible.
So bisphosphonates are not for everybody. Maybe older people, postmenopausal, you will give bisphosphonates definitely. Are you getting late? Are you getting from late?
No, I'm
getting calls. Yeah, we'll just go through that. So what he said, quoting his studies in younger population in the Western countries. No, he did say younger population. So younger population, longer steroid, for example, ankylosing spondylitis, occurs in young males typically. These young males are given naproxen or indomethacin for months together in the lowest possible dose. So that is fine. But the older the person gets, the more renal compromise, hypertension, failure you will see with NSAIDs. So I think younger patients you can take a risk with monitoring. Older patients is a problem. At the same time, he is saying lowest possible dose, shortest duration possible for both NSAIDs, steroid. No, but I'm saying context ऐसा था कि younger people you give bindas. Chikungunya occurs in a young person. You give NSAIDs for a longer time just because the quality of life is so compromised, and you give. per se, what I do in chikungunya, for example, is I refer to homeopath as soon as possible. And for whatever work, 30-40% placebo effect bolo, ya kuch bhi bolo, we are satisfied. Patient does not move from ortho to ortho to ortho, or because the more physicians they go through, the more toxic drugs they are getting. And as he said, DMARDs in chikungunya, they don't have a proven role, but they are given. Why are they given? Because there's nothing else to give. So I would rather be safe there. And in the elderly patient, we know that NSAIDs given for even beyond 5 days can cause problem. So if you are giving NSAIDs, closely monitor the patient. Dr. Subodh Nartani, you are asking me something about? Nothing. Okay. So any patient who's on long-term steroids, one, if the patient is older, you must put the patient on alendronate, that is a bisphosphonate, or zoledronic acid, which is an injectable bisphosphonate. You must start a bisphosphonate in all patients on more than 3 months of steroid, especially if their age is high, or in some patients who are younger but on a higher dose. 7.5 milligram per day is the usual cutoff. If they are more than 7.5 milligram per day and they are on long-term steroids, whatever the age, you may consider giving bisphosphonates. Yeah. So dexascan is not recommended here because this is a prophylactic. Osteoporosis need not be documented. You are giving as a preventive, the alendronate. You are asking, sorry. You tell me when you want to go. Just take it. You want to go now also? Please. Okay. We have not given them a brief about seronegative spondyloarthritis. He said seronegative spondyloarthritis are 4 varieties that he said. Psoriatic, reactive,
I think ankylosing spondylitis, psoriatic arthritis, and reactive arthritis is 3 most commonest things. You identify them with.
Very quickly.
So there are
How do they suspect anti-inflammatory?
6 to 7 common features. They have inflammatory back pain. Inflammatory back pain does not mean you have early morning stiffness. Most inflammatory back pain is defined by buttock pain, which is more at the later half of the night, more while sitting, more while sleeping position. They can sometimes play cricket and dance, but they can't sit or sleep, and especially the later half of the night. Early morning stiffness is there, but the problem with early morning stiffness is every back pain has early morning stiffness, even mechanical back pain. So if let's say inflammatory back pain or ankylosing spondylitis back pain has early morning stiffness, say in 90% of the patients, even mechanical back pain or non-ankylosing spondylitis back pain also has stiffness in 60% of the patients. So it's not a good criteria to differentiate. So any low back pain below 40, below 45, below 50, or starting below 50 and persisting, you should suspect angst, especially if it's more at the night, more in the buttock regions. Okay, and it is more troublesome when you get up in the morning, especially for 30 to 40 minutes. And physical activity makes it better. Or one single dose of NSAID makes it better. That's the beauty of spondyloarthritis. Sometimes one combiflam can make them run for 10 days. And that is the only treatment required at some time. So these are the features where you should suspect ankylosing spondylitis. There are some ankylosing spondylitis patients who can present with knee synovitis, wrist synovitis, but it is usually asymmetrical, large joint. vis-a-vis rheumatoid. Rheumatoid में usually will give small joints, but इसमें asymmetricity होगा. ज़्यादातर कैसा होगा, एक नी होगा, एक एंकल होगा, एक wrist होगा और एक PIP होगा. रूमेटॉइड में कैसा होगा, नी भी होगा, एंकल भी होगा और सब MCPs और सब PIPs भी होंगे. So this is how we differentiate spondyloarthritis. The only spondyloarthritis, psoriatic arthritis, can behave exactly like rheumatoid. So whenever you have a patient who is behaving like rheumatoid but there is everything negative, I always ask for psoriasis. And the biggest hidden factor is scalp. You have a big patch of scalp dandruff, that is psoriasis, unless proven otherwise in this context.
Can you define for us reactive arthritis? What is reactive?
So reactive arthritis is sudden acute onset, severe swelling of joints, sudden explosive onset with inflammatory back pain, because remember reactive arthritis is like spondyloarthritis, which can also have sacroiliitis, and you have large joint swelling, more predominant than small joint swelling, along with inflammatory back pain or dactylitis. You know what is a dactylitis? So any toe joint which appears like a sausage, just hit the word dactylitis on Google today. You will see this large second or third toe joint which will appear like fully swollen. It will become dark red or dark black, because we are dark stone people, and it will be very swollen, almost double the size or triple the size. That time you should suspect three things. Either it is reactive arthritis, especially sudden onset. If it is slightly gradual, it is psoriatic arthritis. And if you have a recurrent history of gout attacks, it could be gout dactylitis. But if you see a swollen dactylitic toe, it's usually psoriatic arthritis or reactive arthritis. Reactive arthritis is very sudden in onset, requires high dose steroids. Psoriatic arthritis is very subtle in onset, and usually you will have a history of psoriasis. Fingers can get involved, but reactive arthritis, the way you will see now, you will get lot of back pain and you will get lot of asymmetricity. Suddenly, एक knee swollen हो गया, एक wrist swollen हो गया, similar to what ankylosing spondylitis patients can get, but in a more acute form. And remember that bad reactive, mild reactive में कैसा होता है? You get mild ankle swelling, post diarrhea, post UTI, GP ने NSAID दिया, चला जाता है. Those patients don't need much. Severe reactive happens in HLA-B27 positive patients. So if you see reactive arthritis, HLA-B27 positivity in community reactive arthritis, which is present into GPs, HLA-B27 positivity rate is less than 20%. But if you see reactive arthritis in a rheumatology clinic, very severe versions, HLA-B27 positivity is 80%. Now even they will have sacroiliitis on MRI, they will have a knee swelling, they will have an ankle swelling, and they will have HLA-B27 positivity. So I see the context. Sudden onset हुआ है, 2 महीने में 3 महीने में suddenly बहुत swollen हो गया है, तो it is most likely reactive arthritis. It will go away.
What is the history given usually of infection? Is it always there?
It is not always there. Most often than not. I'll tell you a story. So there is a patient. There are many patients, including this has happened in my family also. So my real Goa's son has ankylosing spondylitis since last 20 years. So he's obviously HLA-B27 positive. Obviously, it was coming from mother or father. We never had to check my Goa or Fufa for that. But one day, at age of 70, my Fufa developed a severe swelling of his wrist and knee joint. Okay, so they are in Rajasthan. Ortho like, अरे ये तो कुछ rheumat लग रहा है, कुछ rheumat लग रहा है, आप अपने भतीजे को phone करो. So I called. I'm like, what's the history? Sudden onset. I'm like, now the son has 20 years history of young spawn. He's HLA-B27 positive. So either of them are HLA-B27 positive, and the history is sounding like reactive. So he may be HLA-B27 positive, and he was HLA-B27 positive. So it came from the Fufa. So the Fufa's first documented episode of arthritis is at 70 with the same gene. And the brother is having ankylosing spondylitis since 20 years. Every year, 4 बार तो we talk to each other because he has young spawn. It keeps on flaring, keeps on subsiding. Fufa's episode went away in 1 month of some steroids, and we gave him biologic because he is diabetic. We did not want to give steroids. And he has never required medicine for last 5 years. The brother continues to be on medications. Similarly, I had a patient who is known angstpond for 16 years or 12 years or 10 years. I don't remember the context. His mother underwent a hysterectomy. 10 days later hysterectomy, she got florid synovitis of knees, ankles, back pain and wrist pain. Now post-surgery reactive arthritis, we know stress can cause it, but we are not very keen to make it. But her MRI showed bilateral sacroiliitis. Her knees were swollen, ankle were swollen, and she was HLA-B27 positive. But this was the first documented episode of her life. We gave her high-dose steroids, and within 3 months, she became absolutely fine. And we haven't given her any treatment thereafter. Her son continues to be on treatment. The son was in Nagpur. He was showing to a different rheumatologist. But because her mother got it, and she was in Mumbai, she came to me in Mumbai.
So the son continues to be on treatment with a rheumatologist, but the mother has gone off treatment within 3 months. So the mother, despite having sacroiliitis and HLA-B27 positive, is reactive arthritis.
So just to put this in context, for example, in thyroid, a family can have a hypothyroid patient and a hyperthyroid patient, Graves' disease and Hashimoto's thyroiditis, and both will have anti-TPO antibodies as one common positive test. Similarly, in patients who have HLA-B27, one person may have HLA-B27 related ankylosing spondylitis, one may develop reactive arthritis, which is also HLA-B27 related. So, different, because this age of onset of ankylosing cannot be older age. Ankylosing has to be younger age. So that's why they suspect reactive arthritis if the person is older, and they would have suspected maybe ankylosing in the patient.
Yeah, so sudden explosive onsets. So I have a cousin who says कि मेरे को एक बार ankylosing spondylitis हुआ था, मेरे को 4 लोग उठा के लेके गए थे to so and so rheumatologist. He made me better. He's actually B27 positive, but it got better in 3 months. So that was reactive arthritis episode. 10 years later, he has got a single uveitis episode. It again subsided on its own. In between, no back pain, no nothing. So he had probably one reactive arthritis episode then, and probably one uveitis episode then. It doesn't matter, because in between he's absolutely fine. I am not going to treat him, and he's not having chronic back pain. He may have some reactive changes in the sacroiliac joint even now, but he's not having inflammatory back pain now, and he's not bending forward, he's not fusing. So he's probably not ankylosing spondylitis. He just had reactive arthritis that time, went away, and probably had one episode of uveitis and may have one reactive arthritis episode 5 years down the line. Who knows? But he does not need continuous treatment. And the label of AS, that AS label is very harmful, because you are talking of a lifelong label. Reactive arthritis is intermittent. It will go away.
Okay. Before we leave, AS label you were talking about, how good is MRI to differentiate AS from other seronegative? MRI of the...
So you have to again do the right MRIs. Yesterday we got a patient who had done an MRI lumbosacral spine. So when you do a lumbosacral spine, the sacral joint is screened, but the screenings are big cuts. And sacroiliac joint is supposed to say this big. And if you just take 2 cuts and there is inflammation in between, you won't find it. And you don't get that detailed pathology. And you are going to label that patient as axial spondyloarthritis, and maybe this will be a lifelong disease. The patient has done MRI 2 days back. So I scaringly told them, can you do a repeat MRI? 9 out of 10 will say no. Sir, आप दवाई दो देखेंगे. But she was educated, understood why I am saying so. उसने बोला हाँ सर पेन तो बटक में हो रहा था, सेंट्रल स्पाइन का MRI किया. So MRI SI joints is very good, but you need to order an SI joint MRI if you are having buttock pains. If you are having lumbosacral pain, then it's fine. But if in young patient you are suspecting spondyloarthritis, 9 out of 10 you may pick up on a lumbosacral MRI also. But I will say कि radiologist को कि you look at both SI joints also and lumbosacral spine also and take detailed 1-2 sequences extra ले लो, 1000 रुपए शायद extra लगेगा, and try to take CT cuts so that you may find erosions also, and you may not be confused with the with something like osteitis condensa ili also.
CT SI joint?
No, I will.
MRI SI joint.
So I write MRI SI joints AS protocol. Good centers do CT cuts. I have a tendency to write MRI SI joints with T1 T2 stir sequences. Stir is an inflammatory sequences. They any which ways do it. If you don't write MRI SI joints with CT cuts to suspect
for suspected
ankylosing spondylitis or spondyloarthritis is how I put it. There are very few patients who don't have any inflammation in SI joints and only in the lumbosacral spine. That is very, very rare. It can happen in patients with psoriatic arthritis, but very, very uncommon in patients with spondyloarthritis. That's why we are always screening the SI joints rather than the lumbosacral spine.
Since we are on the lumbosacral spine, a very quick word on chronic low back pain.
Very difficult, very difficult to treat, and it can be a part of larger chronic pain syndrome like fibromyalgia. Exercises, meditation, and praying that that patient does not come back to you and goes somewhere else is what I do. Or everything with chronic pain, we don't like it. You can't. I am very happy with 30 Solon joint of rheumatoid. He is going to become my fan with 40-55 mg of Visolon, और मैं उसको कल खड़ा करूंगा और वो घर पे जाके मेरी ख्याति 10 जगह फैलाएगा. क्रोनिक पेन एंड फाइब्रोमाइल्जिया 6 बार आएगा, गाली देगा, हर ओपीडी का विजिट 30 मिनट्स का होगा, और आप अपना सर पकड़ लोगे. There are some fibromyalgia patients, नाम लिस्ट पे आता है ना, I start get palpitations. It's so bad. It's just that we are so talkative at times and we have acknowledged they have disease. They are patients who have 10 files. Neurologist for headaches, chest physician for costochondritis, back pain के लिए spinal surgeon, spinal injections, 10 physiotherapists, huge amount of files. एंड कोई रिपोर्ट में कुछ नहीं आता है. इनका ESR भी 2 आएगा, CRB भी 4 आएगा, लेकिन पेशेंट तो परेशान है ही है, पेशेंट का पति और घर वाला एक्स्ट्रा परेशान है. एंड द बिगेस्ट प्रॉब्लम इज यू आर द ओनली वन हु टोल्ड द पेशेंट कि नहीं मैम आपको फाइब्रोमाइल्जिया है, तो पेशेंट इज योर फैन. वो ठीक नहीं हो रही है, बट यही डॉक्टर है जिसने कोई तो बीमारी को
रोग है.
हाँ रोग है.
पागल
एंड इफ यू टेल द पेशेंट कि ये मन की बीमारी नहीं है, इसको एक्चुअल प्रॉब्लम है, तो भले पति खुश हो कि ना हो, फीमेल तो फैन होगी, वो हर बार आएगी. लेकिन वो ठीक होगी कि नहीं इसका गारंटी नहीं. बट हैविंग सेड दैट, we are successful 70% of the times, and believe me, in chronic pain it is not a bad number because we counsel a lot. मतलब मेरे को अच्छा नहीं लगते हुए भी, मतलब अंदर से मन ये हो रहा होता है कि नहीं बोलना है, तो भी we speak a lot. We give them lot of neuromodulators, lot of pregabalins, lot of amitriptyline. In any chronic pain I do that. You will be successful 60 to 70% of time, acknowledging them, making their sleep better, not giving them benzodiazepines. Try to give them low dose antidepressants. You can use duloxetines, you can use pregabalins, you can use gabapentins. Use pregabalin when the patient is thin because it causes weight gain. Use gabapentin or amitriptyline when the patient is obese. And duloxetine is weight neutral. So you can use those therapies. Use in low doses. Keep on telling the patient 40% પણ બરાબર સારું થઈ ગયું તો બહુ સારું છે. 40% भी आप इंप्रूव हो गए तो समझना आपने गट जीत लिया. पेशेंट बोले हाँ 40% भी अच्छा हो जाएगा, 10 साल से पेन है, बहुत अच्छा है. एंड गिव देम स्मॉल डोसेस ऑफ NSAID एंड गो and push them to physiotherapy and ask the physiotherapist to not use machines. Use exercises. My physiotherapy protocol is core, back, hands, knee, feet, all painful areas. Gradually stretch, gradually strengthen them. Use TENS and USG to bare minimum. If patient is not affording, encourage patient to come twice a week, but continue the physiotherapy. Consider dry needling for trigger points. They have lot of trigger points. So any chronic pain has trigger points. If you have low back pain, you will find that there are 2 trigger points. If you dry needle them and give good physio, 40-50% will become your fan.
What is dry needling?
Dry needling mein what you do, so basically the concept is you get these triggers or knot formation which are releasing inflammatory cytokines, and they are traveling to the dorsal horn ganglia and it is going to the brain and making pain sensitization. So one trigger point can lead to pain in the whole body. The other example, if you have a bad toothache for 5 days or 10 days and if you don't address it, by 11th day your whole body will start paining. You will start getting chidchidapan. Even not 10 days, 1 day. So what is happening, that your pain is traveling to the brain, making you very irritated and then started spreading pain everywhere. This can happen with a chronic visceral disease. So fibromyalgia will always be seen in patients under chronic stress, in chronic illnesses. So many of my rheumatoid patients have fibromyalgia if you don't tackle them right at the start. Very easy to make the joints less swollen, but it's very difficult to treat chronic pain. बहुत बार पेशेंट आके फाइल फेंक देता है, बोलता है सर 6 दवाई ले रहा हूँ, कहीं पण सारू નથી. Usually these are patients who have fibromyalgia. All the joints are silent, but इधर टच करो पेन है, इधर टच करो पेन है. They don't need medications. They need lot of neuromodulators, and more than that they need exercises and meditation. So basic principle of chronic pain is exercises, releasing the trigger points.
So what is that trigger?
So trigger points is basically muscle knots. So needling mein what you do is you poke it and you try to dismantle that knotting, and with a acupuncture needle. It's not acupuncture. You use an acupuncture needle and you poke it. The patient will be much better the next day, but you have to follow up with physiotherapy. Otherwise that patient will form a trigger point again. So you are breaking the cycle of pain. And if you see videos of pain sensitization, you will see patients with chronic back pain. they have lot of sensitization here. You touch that. This is a very common point. I bet you at least 30% of people right now have lot of trigger points in the neck. Okay. But you are not a chronic pain patient. But if you don't tackle this now, slowly and slowly your whole back will start paining. So you have to start doing your neck exercises, doing some massages. And if you start doing exercises for 10 days, 15 days, you will get better. But in very severe chronic pain, now the trigger points are so hard found. It's very difficult to tackle them. So what they do is they can also do ultrasound, find muscle knots and inject with lidocaine. That is called wet needling. Now in chronic pain, it's very, very difficult to treat. Now problem is now anesthetist or jo bhi pain specialist, they take 3,000 rupees for one trigger point. It's very simple to do it actually. We can do it for free.
Can the family physician learn?
Family physicians can learn. Yeah, it's very easy. I think you can see a lot of videos. I don't have the time to do it. I have under-self courses myself. And actually in those times when rheumatologists have had trigger points and we have dry needled them, they have got a lot of pain relief the next day. But you have to follow up with avoiding posture abnormalities. You can't think that dry needling will take away the pain. It will take away the acute pain. But if you have chronic stress in the family and it is not addressable, you have to give a neuromodulator. So you have to address that. Don't try to label a patient as psycho. If there is chronic pain, drugs may help. If there is a chronic depression, drugs may help. These patients are on borderline depression, borderline You may, and they are not that depressed you need to go to a psychiatrist. But if they are suicidal, you will go refer them to psychiatrist. Because their problem is pain. So you have to take away the pain and then encourage to go there to a psychologist, physiotherapy. So initially I do give some NSAIDs. But I always will taper it down.
I think we will end here. Any questions? Can we it's another topic by itself. We will take it later. What percentage of low back pains get better?
Any chronic pain, you try your best. The success rate is 50 to 60%, especially if there is no etiology. But yes, if you have a chronic radicular pain, which is just located to L5 territory, you have a clear disc pressing the L5 nerve, then you have to operate it or give an injection in that territory. But most chronic pains, you take plantar fasciitis or tennis elbow, which are not self-resolving. Usually plantar fasciitis and tennis elbow are self-resolving. But most chronic pains, once they go beyond 4-5 years, they are going to be lifelong. You can just manage them well. And sometimes the physio will work better and 30% of the patients will just tell you, sir, thank you. You stopped me going to, I have a patient of fibromyalgia. Sir, आपने ठीक तो नहीं किया, लेकिन आपने बोल दिया कि दूसरे डॉक्टर के पास जाना छोड़ दो. Which I think is an achievement itself because she was doing 20 investigations a year, EMG, NCV, MRI brain every year. So she just says, sir, she has put a review on the net. Dr. Nilesh could not treat my fibromyalgia because it is very severe, but he gave me direction that I have fibromyalgia and he made me stop going from the anxiety to go to doctors. And I think that is an achievement itself for a patient who was going from place to place. So this is how we operate.
First of all, thanks, Dr. Nilesh. Big applause for him. A small token from us, sir. And yeah, I hope that you will come back. We will hope to get you. Devesh has a very small point to make.
No, sir. So acupuncture mein we don't do the needling to the extent we do it in dry needling. We go much deeper in dry needling. Sir. But see, the problem with chronic pain now, you have to learn to use the placebo effect also well. Dry needling? No, dry needling mein they have researchers where they have dry needled a point. They have taken tissue samples from that, small tissue samples, and they have not needled and they have taken tissue samples and they have found differences between the level of inflammatory cytokines. And sir. So
reduction in
painful
cytokines.
See, what I'm saying, for chronic pain ना, it doesn't matter आप placebo दे रहे हो, आप क्या दे रहे हो. The ultimate thing is meditation, exercises with some neuromodulators, and you give them pain relief because that is their biggest problem. Acknowledgement is the biggest problem. So I don't go into that territory कि homeopathy से ठीक होना चाहिए. So it may have a placebo effect, and dry needling also has a questionable but only thing is they are trying to research it more, and at least they are building evidence base for it. Acupuncture has fixed point needling. It does not have trigger point needling. In acupuncture you have this chart where you needle certain points only. You don't needle the trigger points. In dry needling, you actually find the trigger points and trigger them, and there are ways to find those trigger points. There are instruments to find those trigger points, and they have found they have a device which is called an electrostimulating device, not easily available in India. They have seen कि when that device goes to that trigger point, the signal frequency increases. So there is something different happening. That device actually sees tissue elasticity. So basically that tissue is getting stiff at that point, and it's just a small point in the body, and you release it, the pain
Whole cycle changes. Thank you so much. Next solo is on the 28th, 29th Sunday again, and it will be with Dr. Vasant Nagwekar on antibiotics. So of course, allopaths will definitely enjoy it. I'm sure that homeopaths might find some benefit in that. Antibiotics with Dr. Vasant Nagwekar. Again, thank you so much.